Couple has two children who are affected by the tuberous sclerosis, and on detailed examination both the parents are normal, but the child first time is having a neurological dysfunction. Then how do you explain this to happen when the parents are absolutely normal, especially in a genetic disease like tuberous sclerosis? What is the phenomena which you are seeing? All of you know what is the meaning of non-penetrance, which is typically seen in the case of the autosomal dominant diseases. There is variable expressivity and non-penetrance. If you take one huge population, though the gene is present, it can't be able to manifest in the whole population uniformly, is basically called as the non-penetrance into the population. Variable expressivity means though the same abnormal gene is there, one fellow has got a severe disease, other one fellow has got a milder disease, is called as the variable expressivity. So it can't be non-penetrance. Let us talk about the other two important concepts. Uniparental disomy, genomic imprinting, let us talk about it. But whenever we are talking about these two concepts called genomic imprinting and uniparental disomy, we can't end the topic rather without talking about Prader-Willi syndrome. There will be a narrow temple distance in the nasal bridge, almond-shaped eyes, mild strabismus, thin upper lip, and a downturned mouth with the overweight. The classical description of a patient with Prader-Willi syndrome. Now, imprinting is one important phenomena which you see in this disorder of Prader-Willi. What is this basically? There is a differential expression of a gene dependent upon the sex of the parent of the origin. Just like in a home, are you the mama's child or you are the papa's child kind of thing. So also happens with the chromosomes. We have chromosome number 11, one coming from papa, other coming from mama. But if it comes from papa only, you are going to show the clinical manifestations, but not if the 11th chromosome's defective gene containing 11th chromosome came from the mother. Then such a phenomena is basically called imprinting, is what I want to underscore to all of you. For example, if you have a maternally imprinted gene, then there is no expression in the offspring of the expression of that bad gene. If it is paternally inherited, is what I want to underscore to all of you. If the abnormal gene is there from the 11th chromosome of the father, and if it is a maternally imprinted disease, the child will not suffer anything unless he inherited that abnormal gene from that 11th chromosome which came from the mother, is called the imprinting. Then what do you mean by uniparental disomy? It is abnormal presence of both the copies of the chromosome inherited only from one single parent, is basically called uniparental disomy. That means, let us say you have chromosome number 12 and you have one particular gene, unless it is there on the two chromosome number 11s, let us say, the disease will not express. But what is happening in the case of the uniparental disomy is, both those alleles which are abnormal alleles are coming from only one chromosome of one parent only. It is not coming from two parents for the disease to express. That is the reason simply inheriting one bad chromosome containing both the abnormal alleles only from one single parent is sufficient to show the disease expression, is basically called uniparental disomy, where both the copies of the chromosome or the part of the chromosome are inherited only from one parent, is what I want to underscore to all of you. If you typically look at the genetics of the Prader-Willi syndrome, classically this phenomena of uniparental disomy is the one which you will typically see, is what you need to basically understand. If you take any autosomal recessive disease, when will the individual show the clinical manifestation of the autosomal recessive disease, doctor? Only if he inherits both those autosomal chromosomes having an abnormal gene. Both the father must give an abnormal gene containing autosomal chromosome, let us say 11th or 12th or 13th chromosome, and also the mother should give, then only he will show the disease. But with the Prader-Willi, what happens is, it is like an autosomal recessive only, but both the abnormal genes are provided by only one single chromosome, chromosome number 15 of one of the parents. So uniparental disomy is the typical feature which you see, that mother's chromosome number 15 contains both the genes which are required to cause the disease expression. Now another important phenomena is called the germ-line mosaicism is a phenomena which you see in the tuberous sclerosis. What is the meaning of this? All of you know what is the meaning of mosaicism. Basically, if the mutation is there in some of the cells but not in the other cells, there are normal cells, abnormal cells, both of them. The mutant chromosome containing cells and normal chromosome containing cells, both of them are there. They will not show any signs of the tuberous sclerosis, but there is a small exception. If a portion of the egg or the sperm cell of the patient, of the parent, is carrying the tuberous sclerosis mutation, then the parent can have more than one affected child. And this is basically called the germline mosaicism, is what I want to underscore to all of you. Why did the parents of this given patient did not express any disease, doctor? Because none of their somatic cells are having any mutant chromosome, but their egg or the sperm is the one which is having that abnormal chromosome of the gene of the tuberous sclerosis contained in it. So there is a reason, though somatically father has no problem, but because it is still there in the germ line and it got transmitted to the child has shown the disease manifestations. Hence it is called as the germ-line mosaicism, is what I want to underscore to all of you. Once more, it is called mosaicism in the father because his germ-line is having the abnormal cells, but the somatic cells are having the normal cells. That's the reason it is mosaicism. And because abnormal is located within the germ-line, it is called germ-line mosaicism, which is a typical phenomena which is seen in the tuberous sclerosis, is what I want to once more underscore to all of you. Now let's go to the next question quickly. Conjugated hyperbilirubinemia, all of you know very well, piggy liver is what you see in the case of the Dubin-Johnson syndrome, where the major problem is that defective secretion of the conjugated bilirubin is the problem in the case of the Dubin-Johnson, is what I want to underscore. Kriegler-Nasser, what is the problem? Glucuronide transferase deficiency. And in the case of the Rotus, it is the uptake problem. So all these things you have to be doubly sure about, doctor. Now the liver in a Kriegler-Nasser, you should not forget the typical brown-black color in large amounts in a coarse pigment called the piggy liver is a typical appearance. At a point of time, portal fibrosis can occur in a given patient who is having the Dubin-Johnson. Quickly rattle out like a parrot, doctor, the causes for the conjugated hyperbilirubinemia. They can be intrahepatic or they can be extrahepatic in nature. So hepatocellular disease like a viral infection, autoimmune disease or alcohol abuse can create the problem within the liver leading to the conjugated hyperbilirubinemia. Similarly, drugs, pregnancy, sarcoidosis, Dubin-Johnson, Rotus and primary biliary cirrhosis and primary sclerosing cholangitis. In all these conditions, they are the intrahepatic causes for the conjugated hyperbilirubinemia. One of the favorite topic of the examiner. You have to be doubly sure about all these causes, doctor. Very easy. If you see with clarity what is happening, you can easily remember. Whereas any obstruction, extrahepatic in location like gallstone, surgical stricture, infection leading to the obstruction of the bile duct drainage, intrahepatic malignancy, pancreatitis, all this can lead to the development of conjugated hyperbilirubinemia as the extrahepatic causes. Now let's go to the next question. Congenital CMV, all of you sure? IgM means recent infection, IgG can be remote infection, IgG can cross the placenta, it may not indicate that freshly the child got infected. That's the reason IgG cannot be of any help in establishing the diagnosis of the CMV, you're all very sure about. But the question is, can urine culture of the CMV can be helpful or not? Which are all the fluids where CMV can be taken and you can prove the diagnosis of a congenital CMV infection or a neonatal CMV infection. Blood, urine, saliva, CSF, bronchoalveolar lavage fluid and tissue from the biopsy specimens anywhere. If CMV is found in a suspected case, you can prove the neonatal CMV infection, hence the urine culture also is going to be helpful. But after you have taken that particular sample, how are you going to know virus is there? Are you going to look in microscope and see for the virus? You need to basically inoculate it on the fibroblast cell culture, typically taken from the foreskin fibroblasts of the humans, and it will produce that classical CMV associated cytopathic effects by which you can prove that there is a virus in the case of the CMV infection, is what I want to underscore to all of you. Let's go to the next question. Acute liver failure, which is the most important prognostic factor. You can't depend on transaminases. Why? Because if a patient presents with a liver failure which is because of the ischemic in nature, ischemic in origin, there can be thousands, 2,400, 3,200 can be the level of the SGOT, SGPT. But once more the shock is taken care and ischemic hepatitis had been taken care and vasculature is replenished and the circulation is once more provided, by second or third day transaminases will once more normalize. So transaminases do not speak anything about the prognosis in a given case of the liver failure. Then what will prove? Prothrombin time, INR, is considered to be the most sensitive index of the liver failure which is useful in the prognostication. Whether it is alcoholic liver disease of an elderly individual with a cirrhosis with the liver failure, it is going to be helpful, or even in a fulminant hepatic failure in a small child pediatric population also, still it is the best indicator is something which you should not basically forget. If the INR is 4 or more, then the prognosis is mortality of about 86%. But if the INR is less than 4, it is as low as 27%. So the most sensitive, specific, essential ingredient in your prognostication should be the INR is what I want to underscore. Let's go to the next question. Regarding celiac disease, we use all these antibodies basically in order to make the diagnosis. But the question of the examiner is which is most sensitive and the most specific out of all this. So basically all of you know it is a wheat, rye, barley and sometimes oats where the gluten can lead to the development of sensitivity which is called as the celiac sprue, where there will be a maldigestion, malnourishment, loss of weight significantly. Simply if you identified it and stopped and removed this from the food of the patient, there is a dramatic improvement in the patient's maldigestion syndrome. Now let us talk about it. Basically if you take these anti-gliadin antibodies, you have two types, IgA and IgG. Between these two, IgA is more specific but less sensitive compared to the IgG type of the anti-gliadin type. But if you look at the sensitivity, the IgA has got 55% of sensitivity and 100% of specificity is what need to be remembered in relation to the IgA anti-gliadin antibodies. In an untreated case of the celiac sprue, a wonderful indicator would be the endomysial antibodies, the serum IgA endomysial antibody. If you take it, it has got a higher sensitivity compared to the gliadin antibody. That is the reason, doctor, a highly sensitive indicator and also a specific indicator would be the endomysial antibody but not the gliadin is what you have to be doubly sure about. Let's go to the next question. A 45-year-old has got a long history of cigarette smoking with the gangrene of the left foot. All of you know thromboangiitis obliterans with Buddha's disease is a classical diagnosis of this classical surgery ward case for passing you out of the MBBS final year. Now the question is, based on the history of the smoker, you must be able to clinch the thromboangiitis obliterans in this case is what I want to underscore. Once more, which type of vessels become involved? It is the small and the medium sized vessels of the upper and the lower extremities. Most important is it must be non-atherosclerotic. A smoker also has a risk of developing atherosclerosis. If that component is there, no more your Burgess diagnosis is acceptable. A non-atherosclerotic segmental inflammatory vaso-occlusive vasculitis involving the small and medium vessels, both the arteries and also the veins of the both upper and lower extremities in a heavy tobacco user is the classical description of the Burgess, which you should not forget. So this is the classical appearance of those ischemic ulcers and the superficial thrombophlebitis which is seen in the case of the Burgess disease is unforgettable. If you do the angiography, you can see the involvement of the small and the medium blood vessels. It is typically segmental in nature, it is not throughout the course of the vessel, and it is more severe distally than proximally, and the proximal arteries are normal, and there is no evidence of the atherosclerosis in this given case, and collateralization with the corkscrew collaterals, classical arteriographic findings which you should not basically forget. Allen's test is a wonderful test to know about the vascular sufficiency and insufficiency, which is highly sensitive, especially in a young smoker. If the Allen's test is positive, then it is almost equal to thromboangiitis obliterans is what need to be remembered. Finally, Olin has given certain criteria before you label it as Burgess disease. The age younger than 45, history of tobacco use, distal extremity ischemia, and excluded autoimmunity, hypercoagulability, diabetes, atherosclerosis as a possible causes of the ischemia, and the exclusion of proximal emboli which are not thrombi which are not embolizing. You have to be doubly sure. Echo is absolutely normal, and all those arteriographic segmental ischemia which you are able to identify is a classical criteria for Burgess. Let's go to the next question. 15-year-old with the restrictive heart disease and endomyocardial biopsy has shown extracellular eosinophilic hyaline material and electron microscopy. What do you expect? Best thing is I don't expect and go to the next question, especially when negative marking is there, because I can bet it, doctor, somebody has answered it correctly means it is sheer, not even 6th sense, 60th sense or 70th sense was working in him. So he is a reincarnation of the passed away soul of a past life mummy of a cardiothoracic surgeon coming and writing the AIIMS entrance can only answer this question thoroughly and precisely. But anyway, we will make an effort to understand it. The Weibel pellet bodies, typically where are they found? They are the electron microscopic marker of excellence of the endothelial cell is what I want to underscore. If you want to say this is a tumor originating from the endothelial cell, Weibel pellet bodies are the ones which are going to help you. Now what are these? Another Greek and Latin word given to you, non-branching filament of indefinite length and cross-banded fibers of 67 nanometer periodicity and whorls. What are the three important findings? What do they signify in an endomyocardial biopsy? Let us basically examine. Basically, these fibrous long spacing collagen fibrils, otherwise called the FLS fibrils, they show about 67 nanometer periodicity. If they are there, it can be a normal finding, it can be an abnormal finding. Normally, you find this kind of collagen fibrils of about 67 nanometer periodicity on electron microscopy in ocular tissue and the nervous tissue. Other conditions is atherosclerotic plaque, Hodgkin's disease, myeloproliferative disease, silicosis, these conditions also. This FLS fibers of 67 nanometer periodicity will be found on electron microscopy. They are not found in the restrictive heart disease, so they are ruled out. Now let us consider the other important possibilities. You have certain fibrous long spacing collagen aggregates which can be found as what you are able to see over here. So now what are the important features in restrictive cardiomyopathy? Let us straight away go to the answer and talk about it. Hypertrophy of the myocytes, myofibrillar disarray, interstitial fibrosis, myocytolysis, they are all the important features which you are going to expect. Especially the disarray of the myofibers is one of the important feature where the myofibers which are resembling the basket weave pattern is what you are going to expect in a given case of restrictive cardiomyopathy is what I want to underscore. So there is a reason, doctor, finally the answer is the non-branching filaments of indefinitive length are the ones by exclusion are the possibilities what need to be remembered, because these whorls of lamellar structures on myocardial biopsy are not found in the restrictive heart disease. They are found in the hypertrophic cardiomyopathy, hypertensive individual, his heart, if you have checked through the electron microscopy, you may find this whorl-like pattern. So there is a reason A becomes the answer over here. Let's go to the next question. There is undifferentiated malignant tumor, you want to do immunohistochemistry, cytokeratin is positive, then what is the most probable diagnosis? So this sentence, there are two clean bowled questions about immunohistochemistry, which we have never experienced or tested in our undergraduation. It is sheer knowledge, doctor, that I mean sheer bookwormness is sometimes tested in the exam. So let us check what it is. So it is the carcinomas which will be staining positive with the cytokeratin. The classical histochemical hallmark is what need to be remembered. So you can see the human skin which is stained with the cytokeratin 19 antibody which will be typically showing this kind of appearance. Let's go to the next question. The patient has got a unilateral ovarian tumor, a 30-year-old female, and there are cells which are showing a doubtful nuclear grooving and a scanty cytoplasm. At the same time, you can't jump to the diagnosis of a granulosa cell tumor because grooving is there, puffed wheat appearance and all that, because there are no Call-Exner bodies. Then what is the immunohistochemical panel which you want to choose as a consultant immunologist of the topmost hospital? So what do you want to choose? But before that, you need to know, as a pathologist, what is the classification of the ovarian tumors? We have surface epithelial stromal tumors, sex-cord stromal tumor, germ cell tumor, or it can be a secondary metastatic tumor. The very premise that it is a unilateral ovarian tumor gives us some important clues. Number 2, the age will give you. So based on that, let us proceed to try to understand this situation. If you take the sex-cord stromal tumors, there are 2 important staining which you have to choose while ordering the immunohistochemistry panel. What are they? Vimentin, keratin, desmin. There are 3 very, very important stains which you have to do if you are suspecting possibility of the sex-cord stromal tumor of the ovary. Why? Because the sex-cord stromal tumors which are mesenchymal in origin will express the vimentin but not the keratin, but not the desmin. So that will help you to know out of the 4 which is the possibility. So unilaterality will give you a possibility of either it can be a sex-cord stromal tumor or a germ cell tumor, and CA125 will help you to identify epithelial tumor. Now what is this S100 immunoreactivity? It will be positive in the case of granulosa cell tumor but not in the other sex-cord stromal tumors. So S100 will help you basically to pinpoint for the possibility of a granulosa cell tumor among the sex-cord stromal tumors. So that's the reason you can also choose the S100 protein for that purpose. And another important clue in the immunohistochemistry is, if you do the immunohistochemistry, there is a strong positive inhibin reaction in almost all the sex-cord stromal tumors and the granulosa cell tumors. So that's the reason if you are suspecting sex-cord tumor in your panel, you must also include the inhibin. And inhibin also will improve the accuracy and the diagnosis. So where is the inhibin among these options? You have inhibin here, vimentin is also there, and epithelial membrane antigen is there. So by all this, especially in view of its diffuse sheets of the small cells, another important clue. And cystic or solid is not helping because both the components are there in it. So A is a possibility in this given case in the immunohistochemical markers is what I want to finally conclude about it. Let's quickly go to the next question. 50-year-old with 3-month history of the pain in the lower third of the right thigh, and there is an intermedullary lesion with a blotchy calcification in the diaphysis, and there is a cartilaginous tumor. You want to differentiate whether it is the chondrosarcoma or enchondroma. Very simple. Enchondroma is benign and chondrosarcoma is malignant. If malignancy is there, what it will do? It will go and erode the trabeculae and the tumor will be permeating into the periphery. The very sensitive and specific both radiologically and pathologically for the presence of the chondrosarcoma in an enchondroma. So the complete transgression to the cortex with a soft tissue component is highly suggestive of the sarcomatous change is what you need to remember. Now I will give a short presentation. A T1 weighted MRI, what you are able to see here is the intramedullary lesion which you are able to see over here, and this intramedullary lesion is having a very low signal intensity, and what you can see is the endosteum is not eroded by it. That's the reason still you can consider it as a possible enchondroma but not chondrosarcoma. So it is that erosion which is a very important feature. Let's go to the next question. Giant cell tumor in the small bones of the hands and the feet. What is the important differential diagnosis? Very interesting question. Of course, at the level of MBBS asking it is a ruthless way of filtering the aspirants, but still doctor, you must be more ruthless to basically be on the top. Quickly 1-2 comments let us take up, doctor, before we forget them. You have the typical locations of the non-ossifying fibroma, solitary bone cyst and chondromyxoid fibroma. You know what is the location? Epi or meta or dia is very, very important. So you have the osteogenic sarcoma in the giant cell tumor located over here, you have the chondroblastoma located over here in the physis. Now invariably one question is going to come simply based on their location. N number of times we have underscored this very important fact. Now this is the typical appearance of the aneurysmal bone cyst, which is one of the important differential diagnosis of the giant cell tumor, is what you should not basically forget. Now if you look at the various, the question was about giant cell tumors DD. You have 4 important conditions which can look like the giant cell tumor radiographically. What are they? In the osteogenic sarcoma you have telangiectatic variety and the fibrogenic variety. These two are the important differential diagnosis. They are eccentric in their location and they are strong mimickers of the giant cell tumor because they are subarticular in their location. Number 2, malignant fibrous histiocytoma is another important entity which can also mimic the giant cell tumor occurring in the similar age group. Similarly, brown tumors of the hyperthyroidism already is a very well known cystic lesion which can look like as such it is giant cell tumor, especially when brown tumors occur in the phalanges is what need to be remembered. Similarly, chondroblastomas are also mistaken for the giant cell tumor, but if you closely look at the radiograph, what you can see is the epicenter of this mass lesion of the chondroblastoma will be lying in the epiphysis rather than in the metaphysis, which is the location where you find the giant cell. Similarly, chondroid calcifications, if they are there, it is another important support for the diagnosis of the chondroblastoma. So now you are all very sure, doctor, the aneurysmal bone cyst, fibrosarcoma, osteosarcoma, hyperparathyroidism, they all can look like the giant cell tumor is what you need to basically understand. Now I will take you through a small radiology gallery of hyperparathyroidism on which invariably one question is going to come. So what you are seeing here, doctor, this small cystic lesion which you are seeing here is a classical example of a brown tumor which you are not going to forget in the hyperparathyroidism. Similarly, you can see here in the inferior obturator ramus the presence of a lytic and a cystic lesion, which is also an example of the brown tumor is what you have to be doubly sure. Now we will give a small quiz. Dr. Raghuram, what you are able to find here, one of the classical lesions of the hyperparathyroidism, what is that called as? How is it looking like? Feel loose about answering it. Losers-Jones is something which you should not basically forget. So Losers-Jones in the inferior femoral neck is something which is unforgettable. Now I will give you one more clue. What is this typical spine in the hyperparathyroidism which you look is typically called as? It is called as rugged jersey spine is a classical feature in the case of the hyperparathyroidism. Similarly, there is a subperiosteal resorption called acroosteolysis. What you can see is at the end of the what you call phalanges, you feel as such somebody has bitten them yesterday night, a rat has bitten kind of appearance, osteolysis. You try to compare the finger of a patient who has got hyperparathyroidism with a subperiosteal resorption with osteolysis compared to that of a normal individual, you can appreciate how the osteolysis is a significant finding. Similarly, you will look for on the sides of the phalanges for the presence of the subperiosteal resorption in a child who is suffering from the hyperparathyroidism. And the skull radiograph is helpful in hyperparathyroidism. It is called the salt and pepper appearance in a given case of hyperparathyroidism, but after you have treated this is the normal appearance which the patient's skull is having, but before that the salt and pepper appearance is unforgettable. Now how about the aneurysmal bone cyst? Typically they are seen in the subarticular cortex and they will be mimicking a giant cell tumor, and that is the reason we need to remember about it. And if you take any given case of the aneurysmal bone cyst, is it often associated with some other tumor? Is there any tumor is waiting behind a aneurysmal bone tumor? Very much. In 29% of cases some solid bone lesion will be there if you have detected an aneurysmal bone cyst. And in about 1/3 of the cases, it is the giant cell tumor which will be the accompanying mass lesion in a given case of aneurysmal bone cyst is what need to be remembered. Now let us go to the next question. Intraocular retinoblastoma, let us talk about this important condition. Once more, retinoblastoma is a stock topic, but examiner went too deep into the retinoblastoma. Is it calcified? Can you detect it with ultrasound? Ragging program was there, so that you have to be doubly sure about, doctor. Basically, what is this Rees-Ellsworth classification? One important classification, very simple. Every tumor has got a classification. Astrological chart need to be given at the end of diagnosing the tumor. If you can't treat it, at least you can palliate. So group 1 are very favorable diagnosis where there is a solitary tumor less than 4 disc diameters in size, and if it is more than 4 into 10 centimeters, and if there is any extension to the anterior part of the equator, and if there are multiple tumors of about 10 disc diameters, it is called grade 4. You need not remember all this, don't worry. At least remember the proper name of the Englishman or a European. Rees-Ellsworth classification is something which you should not forget. Now the question is, what is the purpose of the Rees-Ellsworth classification? Very simple. If I give radiotherapy as a treatment of the retinoblastoma, what is the chances that it is going to regress and the patient is going to improve? To prognosticate in the post-radiotherapy phase how the patient is going to respond in the pre-radiotherapy, this Ellsworth can help like an astrological chart of prognosis is what you need to understand. But there is another pitfall. Probably this question was composed about 10 years back and finally it has expressed it now, because radiotherapy alone is no more the treatment of retinoblastoma. So on the very premise you can discard the D as a truth, but still considering that very nature of it, let us talk about Ellsworth classification. Currently it is the chemotherapy with a supplanted radiotherapy is considered the treatment of choice of the retinoblastoma, but not the radiotherapy alone. In those days when the radiotherapy was alone used, beam radiation, Rees-Ellsworth is a important prognostication factor is what I want to underscore. So now you are very sure about it. Let's go to the other options. Retinoblastoma is basically there on the chromosome 13, all of you know very well, it's a suppressor gene. You need to have a double hit hypothesis, so 2 abnormal genes with 2 mutations must appear before the disease starts to express itself. But the question is, what percentage of cases do you find father and mother or any one of them having leukocoria with a retinoblastoma, finally child having it? Only in about 5 to 10% of cases. 95% of cases it is sporadic in nature is what need to be remembered. But once more examiner wants to know option number B. If I have a sporadic gene of the retinoblastoma, can I be able to transmit it to my child? Is an important question. Very much. Who said no? So patients with sporadic retinoblastoma do not pass their genes is absolutely a wrong statement. They very much pass to their offsprings is the truth. Hence the B is the answer. All the remaining things follow the game. That is, calcification is very much seen, ultrasound is very much used. For the purpose of identifying the calcification is what I want to underscore.